So now we are seeing about the acute leukemias. Let's move on to the chronic lymphocytic leukemia CLL. So it is usually affecting the elderly age group. So the patients are usually more than 60 years of age group, and they come up with the multiple lymph nodes. So generalized lymphadenopathy, multiple lymph nodes will be present. Apart from that, they can also have splenomegaly. Okay, so the genetics involved in CLL will be deletion 13q, which is the most common. So deletion 13q is the most common. Apart from that, you are going to have chromosome 17p deletion, in which TP53 is there, right? 17p. So TP53 is going to be deleted here. Then 11q deletion, then trisomy 12. Okay. So all of these are specific deletions, so you'll have to remember. So deletion 13q, 17p and 11q, then trisomy 12. So all of this is going to be associated with CLL. So when there is a deletion 13q, while reading microRNA, we must have read that deletion 13q is the location wherein microRNA 15a and 16.1 is going to be present. So when this is going to be deleted, these microRNAs are going to be lost, resulting in the upregulation of BCL2. So BCL2 is an anti-apoptotic protein, right? So BCL2 is upregulated. So these lymphoma cells are going to proliferate without any cell death. So what are the clinical features which we see in CLL? So this leukemia cells, the lymphocytes which are forming this leukemia, so these are not forming having a proper function. So they cannot transform into plasma cells and produce proper immunoglobulin. So there is going to be hypogammaglobulinemia, because of which the patients will have multiple recurrent infections. As such, CLL, I already mentioned, CLL is going to have lots of autoimmune pathology associated with it, especially autoimmune hemolytic anemia and autoimmune thrombocytopenia. So autoantibodies are going to be formed against RBCs and platelets here. Because of this hypoglobulinemia, there is going to be some kind of dysregulation in the formation of the immunoglobulins, and they tend to form autoimmunoglobulins. Okay. So this is we have something called as Evans syndrome. So Evans syndrome is nothing but CLL plus autoimmune hemolytic anemia. Apart from that, CLL can also be associated with immune thrombocytopenic purpura. So that is autoimmune platelet dysfunction, right? So platelets are going to be lost because of the autoantibodies. Then the patients can have generalized lymphadenopathy and then organomegaly as well. So when they are involving the lymph nodes alone without the peripheral blood involvement, only the lymph nodes are going to be involved by this pathology. It is going to be given the name as small lymphocytic lymphoma. So CLL was small lymphocytic leukemia, while SLL is going to be small lymphocytic lymphoma because it is involving the lymph node. So in microscopy, if you see, SLL is going to have characteristic proliferation centers. So proliferation centers with the formation of pseudofollicles is characteristic for CLL. So this there is usually if you see in the lymph node, the architecture of the lymph node is going to be effaced. So it is going to be completely replaced by the diffuse sheets of this small lymphocytic cells. So SLL is going to be, as the name suggests, it is going to be an example for small lymphoid lymphomas. Okay. So lymphomas can be divided based on the size as small lymphoid cells, medium sized cells and large sized cells. So small lymphoid cells, the examples will be follicular lymphoma and this SLL. Okay. So here we are going to see diffuse effacement by small lymphoid cells. Apart from that, proliferation centers are going to be characteristic for SLL. Then this SLL can also transform into a DLBCL, which is a large B-cell lymphoma. So small cells are becoming large cells. So a DLBCL kind of morphology it can transform, and it is going to be called as Richter's syndrome. So Richter's syndrome is nothing but transformation of a indolent or a very mild lymphoma into a aggressive type of lymphoma like a DLBCL. So how do you diagnose CLL? So criteria for diagnosing CLL is there is going to be absolute lymphocyte count of more than 5,000. So in the peripheral smear, we have to have a lymphocyte count of more than 5,000 per millimeter cube. And in the bone marrow, the cellularity should be more than 30% composed of this clonal lymphocytes. So these lymphoid population, this clonal lymphocyte population should be occupying more than 30% of the bone marrow cellularity. And apart from that, the characteristic immunophenotype of CLL cells is the CD5 positivity along with CD23 positivity. So if you remember, CD5 was actually a T cell marker, right? And CD23 was a B cell marker. So co-positivity of both this B cell and T cell marker is characteristic of CLL. So very, very important. CD5 and 23 positivity together is seen in CLL, while CD5 will be positive while 23 will be negative in mantle cell lymphoma. And in follicular lymphoma, both 5 is negative and 23 is negative. You'll have to remember this. 5 and 23 both are positive in SLL or CLL, while 5 positivity and 23 negativity is seen in mantle cell lymphoma, and both 5 and 23 are going to be negative in follicular lymphoma. So peripheral smear, if you see, there is going to be increased leukocytosis. So leukocytosis is going to be present, and in the DLC, it is going to be the mature lymphocytes which are going to be seen. So it is with increased number of lymphocytes are going to be seen. And apart from that, so you see, these are all the mature lymphocytes which we are seeing. So apart from that, what are these cells which we are seeing? So they have something like a leaf like this, right? So a smudged kind of an appearance. So these cells are called as smudge cells or parachute cells or basket cells. So these are nothing but a artifactual product, actually, not as such they are formed. So when you are making the smear, this lymphoma cells, leukemia cells, CLL cells are going to be very fragile. So they break while making the smear, and the nuclear content of this leukemia cells are smudged like this. So this violet appearance of this kind of cells are called as the smudge cells, which we see in this CLLs. So bone marrow, I already mentioned, there is going to be increased lymphocytes, at least more than 30% should be there. Flow cytometry, CD5 and 23 co-positivity should be there. So prognostic factors, if you see, deletion 13q, which was the most common genetic abnormality, is a good prognostic factor. While the other prognostic factors like deletion 11q, deletion 17p, trisomy 12, notch mutations, ATM mutations, or ZAP70 expression. So all of this can have a poor prognosis. Okay. ZAP70 expression. This is again a poor prognostic factor in CLL. So treatment, you can use chemotherapeutic agents like fludarabine and ibrutinib. As such, CLL is going to be an indolent kind of a neoplasm.